Okay, very good evening, everybody. Good evening. I hope all of you are well, and I hope all of you are taking care of yourself. Let me just get the things going. Okay, so I hope you all enjoyed the classes so far, and I'll just continue with the radiology. Now, DVT is the biggest revision session that happens for PG entrance in October every year, and this year we will do it digitally to keep everybody safe, and because in the entire country we will have different places have different numbers of patients of corona, so we'll do it digitally, but trust me, we will recreate the magic in the digital world. Okay, so just we are all looking forward to the uh, event, and we'll try our best to make it. Okay, everybody, on your marks now. Let's start going about things. Okay, are you ready? Yes, let me just. Okay, now what I'll do today is, okay, I will carry forward from what we have done so far. I will just, recall what we have done so far. If you recall, beta, let's see. So far in our classes, we have seen what is CT scan, what is a MRI, and we started with neuroimaging, if you remember in our previous classes. We saw chest X-ray, and we begin with the orthopedic imaging. In orthopedic imaging, I have already taught you bone tumors. We have touched upon some infections like osteomyelitis. We were looking at metabolic disorders. Primarily, we saw hyperparathyroidism, we saw rickets, and we saw osteomalacia. Remember? This is where we were. Okay. Now, in addition to this, today I will cover some arthritis, metabolic conditions, arthritis, and we will do some miscellaneous. Okay. So in bone X-rays, the only things that we are left with is we are left with some metabolic conditions, some arthritis, some miscellaneous conditions. And other than that, in the entire of the coming month, you will also have orthopedic schedule. So in orthopedics itself, they will discuss, Dr. Tushar will be discussing a lot of things for you. So this is what I will cover. And after this, I will cover today two things. What is ultrasound? What is Doppler? Which will also help you to understand the obs and gynae images that you are looking at. So I'll tell you the basic principles of ultrasound and Doppler. Everybody clear? Okay. So this is what we have seen so far, and let us, put some tick marks. Okay. And these are the ones which are left. Left. Okay. So this is the plan that we have. Gradually in my classes, I will also show you how to look at IVP. I will also teach you later on how to look at barium, how to look at CT of the abdomen, how to look at mammography, how to look at PET scan, how to see thyroid scan, nuclear scans, and I'll talk about all those kind of things gradually. Okay, so gradually I'll talk about a lot of things, but today my goals are simple. I have to finish with you the bone radiology and ultrasound and Doppler. Easier topics, not much to do, but we will be able to do it together. Okay, so yesterday, if you remember in my last class, we were discussing about rickets, and I'm sure some of you, okay, some of you might have remembered all that, do you remember that rickets has growth plate widening, rickets has, okay, not only do you have growth plate widening, you also have cupping of the metaphysis, fraying of the metaphysis, and splaying of the metaphysis. This is what we saw. But then I confused you by saying, if they say epiphyseal enlargement, you will think of an inflammatory disease called as juvenile rheumatoid arthritis. And this is where we were, and a lot of you then asked me to stop the class. But let us add a word here. Even in hemophilic arthropathy, even if some patient has hemophilia, okay, then also the joint will have bleeding, and because of hemarthrosis, there will be an inflammatory response leading to epiphyseal enlargement. Now, can you tell me two causes of epiphyseal enlargement are? Two causes of epiphyseal enlargement are juvenile rheumatoid arthritis and hemophilic arthropathy. This is where we were in the last class. Now let's go further and let's understand more things before we look at some miscellaneous things. Let's understand more things. Another disease that I want you to learn with me is scurvy. Okay. Another disease in which we have very characteristic X-ray findings is scurvy. Okay. Anybody, listen to me and answer. Scurvy is due to deficiency of vitamin C. Vitamin C is required for collagen cross-linking. So if you have deficiency of vitamin C, you have problem in collagen. If you have problem in collagen, what happens? The osteoid matrix is not properly formed. An osteoid matrix, once it is formed, it undergoes mineralization to form the bone. Okay. Now I want everybody to understand. Listen to me. Listen to me, everybody, and answer. In rickets, the problem was in mineralization. Remember, mineralization is dependent on vitamin D, but vitamin C is the one which is needed for collagen, and collagen is needed for osteoid matrix. That means in scurvy, mineralization has no problem. The problem is in the osteoid formation. Everybody understands? So do you agree collagen is needed for bones as well as it is needed in blood vessels? Okay. So you need collagen in capillaries, you need collagen in the blood bones. So we will see changes of scurvy in blood vessels as well as in the bones. Let's imagine now. Now, bone is formed on a osteoid matrix. Everybody, are you able to follow my point? Bone is formed when there is a osteoid matrix, and when it gets mineralized, the bone is formed. Okay. Now in scurvy, osteoid is less. Okay. In scurvy, the osteoid is less. Okay, everybody clear? Now tell me, if osteoid is less in scurvy, okay, tell me now, I'm sure many of you can answer, the bones will be thin and gracile. Do you understand? When you don't have the ground substance, when you don't have the ground substance to form the bones which will be formed will be thin and gracile. Now understand with me, listen to me and understand. If bones are thin, when you see them on the X-ray, only the cortex will be visible because it is very thin. So we will use a term pencil thin cortex. Okay. Okay, the first page only, beta. Everybody, I am at the first page. Okay. Now, are you clear with this or not? So the bones in scurvy are thin and gracile. That is why you will see a frequently asked question. Scurvy will lead to pencil thin cortex. Okay. Everybody, are you able to understand the concept so far? Okay. Now, second question. Not only that, even your epiphysis will be thinned out. So bones will be thin, only the cortex will be visible, and in epiphysis, only the margin will be visible. In epiphysis, only the margin will be visible, which will look like a ring. We will call it, after the name of the person who described it, we will call it Wimberger's ring. Gracile मतलब बेटा बहुत thin, बहुत पतला है ना. Gracile means very thin है ना. Now let's see if you can answer बेटा. Now see, again understand, if the bones are thin, on X-ray you will only see the margins of the bone, and if the epiphysis is thin, you will only see the margins of the epiphysis. If you see the margins of the bone as if somebody has drawn from the pencil, we'll call it pencil thin cortex. And if you see prominent margins to the epiphysis, it is called as Wimberger's ring. Everybody understands? Everybody understands? Okay. Now let's see if you can understand an answer. Okay. It is slightly complicated, but if you try to understand, you will not have to mug it up. Nahi to you will have to mug it up, beta. है ना? So you remember, if anybody of you can answer, beta, all of you think can answer, beta. Okay. If this is your growth plate, okay, beta. If this is your growth plate, this is your metaphysis. In between, you had the provisional zone of calcification. Now in scurvy, what is happening is provisional zone of calcification has less amount of osteoid. Listen to me, everybody. Listen to me. Okay. In scurvy, provisional zone of calcification has less amount of osteoid. Everybody follows? Now, anybody of you can answer better. Osteoid कम है, लेकिन vitamin D है वहां पे. Vitamin D तो है. So vitamin D acts on provisional zone of calcification and causes mineralization. Okay. Vitamin D acts on provisional zone of calcification and causes mineralization. Okay. लेकिन वहां osteoid now is less. Now let's understand. Now what will happen? You have less amount of osteoid, but vitamin D is depositing calcium at its original speed because there is no deficiency of vitamin D. Now the same less amount of mineral, now try and imagine, यहां पे osteoid कम है लेकिन mineralization उसी स्पीड पे हो रही है. Now what will happen? Okay, if osteoid is less but mineralization is happening at its own speed, the provisional zone will become dense. So what happens in scurvy is your provisional zone of calcification appears more dense, which is exactly opposite to what happens in rickets. This is called as white line of Frankel. This is called as white line of Frankel. Do you understand the concept or not? देखो सोचो कि अगर ओस्टियॉइड कम है लेकिन विटामिन डी उसको पहले की तरह ही मिनरलाइज करता जा रहा है, तो वो कम ओस्टियॉइड ज्यादा मिनरलाइज होके इट विल अपीयर मोर डेंस. And this is exactly opposite to what happens in rickets, and that is why some people believe that scurvy looks opposite to what you see in rickets. Remember, white line of Frankel is seen in scurvy. Any one of you can answer. Okay. Now do you understand? इसको विटामिन सी की कमी है, डी की नहीं है, तो मिनरलाइजेशन अपनी स्पीड पे चल रहा है बेटा. Everybody understands? So let me ask you a question again. White line of Frankel was also seen in healing rickets. Anybody of you can recall this? Healing rickets में भी white line of Frankel था, जहां पे you remember we saw a dense provisional zone of calcification where we saw recovery happening in healing rickets. Okay, very good. Okay, now let's see and understand. Now what is happening in the bone is this is where you have the cartilaginous bone. यहाँ पे cartilage है जिसको growth plate कहते हैं. Then at the provisional zone, it is getting calcified. Now after the provisional zone, what will happen is the blood vessel will penetrate the mineralized bone and form the the vascular part of the bone, and the mature bone will be formed. Now in scurvy, what happens is this phase is also defective because the blood vessels also need collagen. So this area, the bone is not properly formed. This area is called as scorbutic zone, or it is also called as Trummer Feld zone. The key that I'm trying to make you understand here is Okay, the only thing that I want you to understand is स्कर्वी में मेटाफाइसिस पे एक तो व्हाइट लाइन दिखेगी और एक डार्क बैंड दिखेगा, एक डार्क एक व्हाइट. Why it is happening is the white line represents, which is white line of Frankel, it represents a dense provisional zone of calcification. And after that, you have a darker area where the final mature bone is not being formed, which is called as the scorbutic zone or Trummerfeld zone. Okay, everybody understands? Okay, now I'll again and again repeat it, don't worry. But let's first understand the concept and then I'll repeat it again for you, don't worry. But let us first do it in continuity for people who are able to understand. Otherwise, their flow will break. So let's try to understand it once. Okay. Now, another thing that will happen in scurvy is the capillary fragility will be high. In scurvy, your capillary fragility will be high. So, if your capillaries are fragile, they will cause hemorrhages. So, because of these hemorrhages, your periosteum will be lifted up. Because of these hemorrhages, your periosteum will be lifted up, and you might have read about this so far in your biochemistry or any other subject that in scurvy you develop subperiosteal hemorrhages. In scurvy, you will develop subperiosteal hemorrhages. Okay, it is different from hemophilia. In hemophilia, I told you there was hemarthrosis. Hemophilia में joint में bleeding हुई, scurvy में periosteum के नीचे bleeding होगी. And because of the periosteum which gets lifted up, you will start seeing there will be some bone formation between the metaphysis and the periosteum. So the metaphysis will look overgrown till the periosteum, and this will be called as Pelkan spurs. Okay. Just understand. Okay, I'm at the first page only. I will don't label it also. Don't worry. Don't label it. I will label it with you in our X-ray again. Just listen to me for a moment. Okay. I will show you now on the X-ray, and then we will try to understand. Okay. Now I am sure now you will be able to gradually label. This is where you need to label beta. Can you see around the epiphysis the margin is prominent? Around the epiphysis you see a ring-like margin. Let us call it Wimberger's ring. Let us call it Wimberger's ring. Okay. Any one of you, can you see the metaphysis where you have the area of the provisional zone is appearing dense? So the provisional zone is appearing more dense because the osteoid is less, but there is vitamin D which is causing it to get mineralized. So we will find white line of okay, we'll find white line of Frankel. Okay, I will explain better, don't worry. And also see now, just distal to the, I'm repeating now, just distal to the white line of Frankel, can you see there is a darker zone? Okay, this dark zone is called as the scorbutic zone, or we will call it Trummerfeld zone. This dark zone is called as the scorbutic zone, scurvy wala zone, or we say Trummerfeld zone. These are your subperiosteal hemorrhages. Okay, and you can see the white line of Frankel at that area, the metaphysis appears to overgrow and it kind of attaches the periosteum to the metaphysis. This is called as Pelkan spur. This is called as Pelkan spur. Okay, now are you able to follow my point? Okay, so some of you are asking how many pages? Just the first page we are writing. Just the first page we've written. Okay, nothing more than that. We are just at the first page of the class beta. Okay, and the first page of the class was scurvy. I'm repeating for all the children who could not understand. Don't worry. I'm repeating again. So this is your bone. Okay, and I told you that in scurvy, what is happening is osteoid production is less because of problem in collagen, which is because of problem in vitamin C. But mineralization is okay because mineralization is dependent on vitamin D. Okay, so this is what I explained. So because the osteoid is less, the bones will be thin and gracile. Thin bones will lead to pencil thin cortex. Now clear? And thin epiphysis will lead to only the margin of epiphysis will be visible, which is called as Wimberger's ring. The provisional zone of calcification will become more dense because the osteoid is less, but mineralization is happening at its original speed. This area is called as the white line of Frankel. After this, there will be a zone which will be dark because the mature bone is not being formed. That is called as Trummerfeld zone. Okay, there will be subperiosteal hemorrhages and there will be overgrowth of metaphysis, which is joining the metaphysis to the elevated periosteum like this. These are called as Pelkan spurs. Okay, everybody gets it? Okay, everybody follows? Okay, so these are the one-liners that you need to remember. Pencils in cortex, Wimberger's ring, white line of Frankel, Trummerfeld zone, Pelkan spur. Okay, so I repeated everything I think twice, thrice, so that everybody follows the scurvy X-ray. Okay, so we come back. Okay, we come back to this. So what we have seen so far is, I'll just explain to you so that you understand. All I have shown you so far in my image book was I discussed the X-ray findings of rickets in the last class. Then I discussed the X-ray findings of osteomalacia, where I talked about things like loser zones. And then I also talked about a little bit about epiphyseal enlargement, hypothyroidism having epiphyseal dysgenesis, and I talked about scurvy today. Okay, everybody follows? Okay, Pelkan spur is probably a newborn formation by the periosteum. This is Pelkan spur, beta. Can you see it? जहां मेटाफाइसिस तो यहां तक होना चाहिए था ना, यहां तक जो ओवरग्रोथ हो गया पेरियोस्टियम ने जो अपने नीचे न्यूबोर्न बनाया हुआ है उसके कारण बन गया पेल्कन स्पर. This is your Pelkan spur. Okay, now once you are clear, now let's try to understand it further. Now what I'll do is I will show you some x-rays of some arthritis or some joint disorders. I'll show you some x-rays of arthritis. Okay, and when you talk about arthritis, only two arthritis are most important arthritis. Most important arthritis are osteoarthritis. I will only spend 5 minutes on it because I am only wanting to show you the x-ray of osteoarthritis. But in orthopedics, they will spend full day on it because they has a lot of joint replacement and everything is dependent on it. But I will also show you how to identify rheumatoid arthritis. Okay, I will show you what is the difference between on a X-ray osteoarthritis and rheumatoid arthritis. Let us start with basics first. Osteoarthritis is wear and tear of articular cartilage. Okay, everybody clear? Osteoarthritis, if we put it in one line, represents wear and tear of articular cartilage. Okay, So I'm just going backwards for some students that I'm okay. Now better see the arrows have marked that beyond the white area that you see is the white line of Frankel. But after this, do you see there is a dark zone? That zone represents the Trummerfeld zone. That zone represents the Trummerfeld zone. Now I'm coming back to the original diagram again. On the other hand, rheumatoid arthritis represents the immune-mediated inflammatory disorder of the synovium. Inflamed synovium in pathology is called as pannus. Some of you might be able to understand, let's see if you can understand, any autoimmune disease, any immune-mediated disease will lead to immunity acting against our own body part, and that will lead to inflammatory changes. So if I put it in one line, in osteoarthritis, the predominant thing that is happening is wear and tear of the cartilage, while in rheumatoid arthritis, the synovium, the lining of the joint is getting inflamed, which is called as pannus. Okay, now based on this understanding, I will show you how the X-ray appearance will differ. That means, try and imagine osteoarthritis is a very common disorder. Okay, so how will you tell to some relative of yours, if some relative of yours comes and asks you that doctor, do I have a routine wear and tear which happens with age, or do I have an inflammatory arthritis where I need immune modulators, which is rheumatoid arthritis? How to differentiate, I will teach you. Okay, in osteoarthritis, the X-ray initially will show you loss of joint space. Okay, osteoarthritis, the X-ray findings will begin with loss of joint space. Okay, I'm sure most of you will be able to tell me, beta, tell me, loss of joint space क्यों? Joint space किससे बनता है? Joint space is formed by cartilage. Do you remember, in the joint, the articular surface of the bone are lined by hyaline cartilage called as articular cartilage. Cartilage अगर है तो वहां पे cartilage is not seen on X-ray. That is why we see the joint space. So X-ray पे osteoarthritis में मिलेगा loss of joint space. This loss of joint space will be non-uniform. Okay, this loss of joint space will be non-uniform. Any one of you can tell me why? सोच के बताना बेटा, non-uniform क्यों होगा? Because remember, wear and tear will be more in the weight-bearing compartments. मतलब knee में, if you look at the knee joint, the medial tibiofemoral compartment is the weight-bearing compartment. The lateral compartment is not the weight-bearing compartment. So the joint space loss will be more in the weight-bearing compartment. So it will not affect the entire joint uniformly. It will affect the weight-bearing area. Very good. That is the point that I wanted to make. The second point I want you to make here is, please see, if this is your joint, now one part of the joint has become narrow. Now because of the narrowing, the weight-bearing axis will change. Because there is one part of the joint which has become narrow, the weight-bearing axis will change, and you will start seeing horizontal spurs forming around the joint. So the bones around the joint will have horizontal overgrowths happening, which are written as osteophytes. What are osteophytes? What do you write in your notes? Bony spurs from the articular surface which are horizontally directed. Okay, so in osteoarthritis you will develop horizontally directed bony spurs. Everybody clear? Everybody clear? Now what will happen now? Try and imagine this area. It is difficult to understand, so please focus. This area you have articular cartilage. You have cartilage. But in the involved area, there is loss of cartilage. In the involved area, there is loss of cartilage. So the bones are striking each other. बोन्स के ऊपर जो कुशन था कार्टिलेज का वो नहीं है वियर एंड टियर के कारण. सो देयर इज लॉस ऑफ द कार्टिलेज व्हिच वाज causing cushioning. Now the bones are directly hitting each other. When the bones are directly hitting each other, the trabeculae, the bony trabeculae get compressed and this area becomes dense. This is called as subchondral sclerosis. There will be increased density of the articular surface because of the bones hitting against each other repeatedly causing sclerosis. We will say subchondral sclerosis. Okay. Another point to remember is you will also now notice that sometimes when the bones are hitting against each other, you will form subchondral cysts which are called as geodes, and you might also form loose bodies. कोई हड्डी का टुकड़ा टूट गया, so it will float in the joint, we call it loose bodies. Okay, so I will revise it and you will hear whatever I am telling you, you will hear. Okay, you will hear it multiple times in orthopedics. Now, why loss of joint space is happening, beta Sri Lakshmi? Try and understand. Because the joint asli mein there is no joint space. So you understand, in a cadaver there is no joint space. Joint space is only seen on X-ray. In a cadaver, the articular surfaces of the bone are covered with cartilage. Okay, but you don't see it on an X-ray. That's why we see joint space. If the cartilage is lost, the joint space will be lost. Do you understand? Now, are you able to understand the concept? Okay, I'm again repeating. In osteoarthritis, everybody repeat after me. There is wear and tear of the articular cartilage leading to a non-uniform loss of joint space, more in the weight-bearing area, with osteophyte formation, which are bony horizontally directed spurs. There will be bones hitting against each other because there is no cartilage in between. So the articular margins will have sclerosis, subchondral cyst formation, loose body formation. Okay. This is something that you will read in orthopedics again. Okay? Don't worry about it. My goal is to show you how a radiologist thinks and how I differentiate from rheumatoid arthritis. Please see with me. Suppose this is your joint. This is one bone. This is another bone. This is your synovium. Okay, lining of the joint. And the joint is covered with cartilage. So this is where you have your articular cartilage. Okay. Now imagine, I want you to imagine with me what happens in rheumatoid arthritis. Rheumatoid arthritis is an immune mediated disorder. It's a rheumatological disorder. You might have studied this in your rheumatology. So in rheumatology, what will happen is if there is a disease which is inflammatory, like rheumatoid arthritis, try and imagine this synovium will become inflamed. Now, whenever the synovium becomes inflamed, you have increased blood flow in the synovium. We will call it hyperemia. In rheumatoid arthritis, the synovium will get inflamed, and that is called as inflammatory response. That will lead to hyperemia, increased blood flow. Now, do you remember from my last class, wherever you have blood vessels in the bone, the blood vessels, they steal the mineral from the bone to maintain the blood calcium level. Okay, so blood vessels are stealing the mineral from the bone to maintain the blood calcium level. Now, if you have more blood vessels because of inflammation, what will happen? There will be more demineralization. That is why The first X-ray change that happens in rheumatoid arthritis is periarticular osteoporosis, which was not seen in osteoarthritis at all. Do you understand the concept now? Or you might have seen this question also. It's a very frequently asked question. Okay, what is the first X-ray sign of rheumatoid arthritis? The answer is periarticular osteoporosis. But do you now understand why it is happening? Okay, why it is happening? It is happening because the synovium is inflamed. Inflammation leads to hyperemia. Increased blood flow leads to demineralization in the bone. If you recall from my last class, absent blood flow leads to sclerosis. You remember, जहां dead bone था वो ज़्यादा dense हो गया था. Okay, absence of blood flow leads to increased density. Increased blood flow leads to reduced density. That is the rule of the thumb in the bone. Are you clear with this? Okay. Okay. Are you clear? You just give me 1 second. Okay, so I'm so sorry in between I had to go. So I am sure you are able to follow my points so far. Yes. Okay. Now why epiphyseal enlargement is not happening, beta? Please see. बेटा now अभी आप नहीं समझ पा रहे बेटा. जुवेनाइल रूमेटॉइड आर्थराइटिस बच्चे में होगा तो उसका एपिफाइसिस ग्रोइंग होगा बेटा, ग्रोइंग एपिफाइसिस होगा. And that is why it was getting enlarged. Okay, are you clear with this or not? While adult में epiphysis बड़ा हो चुका है, वो और बड़ा थोड़ी होगा. Now do you understand? When you are, listen to me, when you have already grown up, then even if I give you more food, you will not become more taller. Similarly, this is what is happening. JRA is seen in children. This is adult. Are you now clear, beta? Some of you were asking this. Okay. Okay. Now let's see if you can answer another question now. Okay. Now in rheumatoid arthritis, wherever inflamed synovium is touching the bone, that part will start getting small destructions. जहां जहां inflamed synovium bone को touch कर रहा है, it will cause destruction, localized destruction. That is called as erosions. Okay, that is called as erosions. So in rheumatoid arthritis, after periarticular osteoporosis, you will see marginal, that means at the margin of the bone, bare area erosions. Okay. Now, why this bare area erosions are happening? Listen to me. Okay. Okay. So let me announce the question some of you are asking, because some of the regular batch students had missed out on general pathology. So we have requested Dr. Sanjeev to take 1 day full, your general pathology only for regular batch on 28th. Okay. Everybody gets it? Okay. Because some of you had attended, some had missed, there was some confusion. So we have rescheduled the general pathology again. Okay, everybody gets it? Now, what do we mean by bare area? Bare area means that if this is the cartilage, so your joint is covered by cartilage, which is giving some protective effect. But at the margin of the joint, there is a part which is within the joint but not covered by cartilage, so we'll call it bare area. That is where the erosions in rheumatoid arthritis are seen first. So rheumatoid arthritis begins with periarticular osteoporosis, okay? Then you have marginal bare area erosions. Then what will happen? Inflammation will lead to destruction of the cartilage also. Inflammation will not only destroy the bone, it will then start to destroy the cartilage also. So when the cartilage is destroyed because of inflammation, what will happen? Better listen to me. What will happen? There will be loss of joint space. But this time, please note a key word that will help you in your exams a lot. It will be uniform. Why? Because inflammation has nothing to do with weight bearing. Inflammation will destroy the entire joint. Okay, so that is what is called as uniform loss of joint space. Then what will happen after that? After that, you will develop things like dislocations and you will develop deformities, which you will study in your other subjects. You might have heard of things like swan neck deformity or boutonniere deformity. So the hands and fingers will become deformed, which you will read when you read deformities in other subjects. Don't worry about that. My goal is to draw a comparison. Okay. Now, if you see the differences now, okay, let's try to understand the difference. Rheumatoid arthritis begins with periarticular osteoporosis, while osteoarthritis begins with non-uniform loss of joint space. The loss of joint space in osteoarthritis is non-uniform. In inflammatory conditions, it is uniform. Inflammatory conditions will lead to erosions, marginal erosions in rheumatoid arthritis, while in osteoarthritis, we saw the word osteophytes. There was increase in the density. We saw subchondral sclerosis. Some pieces were broken. There were some cyst formations. So this is all wear and tear. Okay, everybody understands? Now, once you know the broad principles, once they are clear, now let me ask you, okay, let me ask you a question. This question will tell me if you have understood the thought process or not. Earliest X-ray feature of tubercular arthritis is. Let's see how many of you can answer this question now. Okay. If you have understood the concept, you will be able to do it. Everybody understands? Okay. Let's see if anybody. Earliest X-ray feature of tubercular arthritis is. Any one of you can answer better. Okay. Now, if I take you back and I ask you, TB is an infection. It's an enemy. And any enemy, when it attacks our body launches a defense against the enemy, which is called as inflammation. So TB will have inflammation around the joint because it's an infection. So that is why the first X-ray finding will be periarticular osteoporosis. Are you able to understand? So are you able to understand? The key is not in what to think. The key is in how to think. आप समझ आए? So now I hope you appreciate that I taught you X-ray features of rheumatoid arthritis, but we were even able to answer X-ray features of tubercular arthritis. Because we understood the key is in inflammation. It is in the basics. It is not in the hi-fi things. Okay. Now, second question. Will you have erosions in tubercular arthritis? Will you see erosions in tubercular arthritis? The answer is yes. Okay. Answer is yes. Again, even in TB arthritis, because it's an inflammatory condition, it will cause localized destructions around the joint. We'll call it erosions. And will you have loss of joint space later on in TB? Yes, inflammatory disorders also lead to loss of joint space. My question to you is only one. Let's see how many of you can answer this, beta. Let's see if you can answer my question, beta. Okay. Loss of joint space जो TB में होगा, will it be uniform or non-uniform? अब रटे बिना बता देना. ट्यूबरकुलर आर्थराइटिस में जो लॉस ऑफ जॉइंट स्पेस होगा वो यूनिफॉर्म कि नॉन यूनिफॉर्म? इफ यू कैन आंसर दिस बेटा, इफ यू कैन आंसर दिस, द आंसर इज uniform. Are you clear? Are you able to understand this? Uniform. Why? Because it's an inflammatory condition. These three things in TB were described by a man called as Phemister. To give him respect, in tuberculosis we call it Phemister's triad. And you might have seen this question in 2019 in NEET PG exam as well. Phemister's triad. Okay, now do you understand that because we were going in the understanding manner, we could predict what Phemister predicted many years back. Now you have become better than Phemister. Okay, so this is what is called as Phemister's triad. Phemister's triad is seen in tubercular arthritis, described by Phemister for TB. It only means periarticular osteoporosis, erosions, loss of joint space. Now let's apply some more common sense. You might ask me, sir, यही सब तो rheumatoid में भी था. Sir, we saw the same things in rheumatoid arthritis also. But let's understand the difference. Okay, let's understand from very basic. TB is an infection. Rheumatoid arthritis is an immune-mediated systemic disease. So do you agree if I now tell you rheumatoid arthritis is usually bilaterally symmetrically involvement is seen, while TB is usually asymmetric? Are you able to see the logic behind or not? Okay, now do you see that I could predict your answer now? Are you able to see this? एक immune mediated systemic बीमारी है तो वो दो तरफा सिमेट्रिकल होगी ना. इधर के जॉइंट में भी ऑटो इम्यून है, इधर भी है, जबकि टीबी में ऐसा नहीं होगा ना. TB would be usually at one joint, or if both, then also it will be asymmetric. The asymmetry will go towards infection. Bilateral symmetry will go towards an immune-mediated symmetric disorder. Everybody understands the concept? Concept समझ आया? Uniform और non-uniform का concept एक बार फिर बता देता हूँ बेटा. Listen to me. If it is a wear and tear disorder like osteoarthritis, it causes loss of cartilage in the weight-bearing compartment. So there is a non-uniformity. While I will now, maybe I can show you an image and then we'll come back to this also. While try and understand, in inflammatory conditions, the entire cartilage is destroyed. So there is no predication for weight-bearing compartment. So it is uniform loss of joint space. Okay. Now let's see and understand. Okay. Everybody understands? Let's go back and we see the image and then we'll come back with another concept. Okay. Let's see the image. Some of you are unable to understand, so I'll show you the image. Now, see this X-ray that you will see multiple times in your clinical practice. And ये तो देखोगे बेटा, ऐसा हो ही नहीं सकता ना देखो. What do you think there is? Okay. So look at this. There is loss of joint space. Uniform ki non-uniform? Beta ji, tell me, do you see loss of joint space? Yes, which is non-uniform. It is more in the medial weight-bearing compartment. Okay, it is more in the medial weight-bearing compartment. Now tell me, should I think of inflammatory disorder or wear and tear disorder? Inflammatory सोचें कि wear and tear सोचें? Now we will think of wear and tear osteoarthritis because it is non-uniform. Another thing that you can notice here is, if you look at the margins of the joint, which I have marked with the arrow, these margins are dense. These are dense. We will call it subchondral sclerosis. So this is a typical X-ray showing you osteoarthritis of the knee, non-uniform. Look at this. Now some of you were unable to understand. Now look at the lateral compartment. Do you see the cartilage in the lateral compartment is preserved and the joint space is preserved? Everybody understands the concept or not? Okay, now let's go further. Okay, look at the X-ray here. Is it the X-ray of one hand or both hands? You can see X-ray of bilateral hands, both hands. Okay. Now I want you to focus on what I'm trying to show you. Look at this area. What joint is this? MCP, metacarpophalangeal. Look at this area. What do you appreciate here? What do you appreciate in the X-ray that I'm trying to show? You can appreciate there is, okay, periarticular osteoporosis. There is periarticular osteoporosis. Are you clear with this or not? Are you making a concept better or not? Okay, so periarticular osteoporosis makes me think maybe we're looking at an inflammatory process. Then when I look at both the hands, I see that this inflammatory process is involving symmetrically both the hands, telling me it's a systemic inflammatory process like rheumatoid arthritis. I also want you to look at this area, and I'm sure some of you will be able to answer. Please look at it with me. Look at this margin of this metacarpal. Can you see, because of the inflammatory joint disease, you can see there is a marginal erosion. This is what is called as marginal erosion. Everybody understands? This is marginal erosion that you see in rheumatoid arthritis. And you can even appreciate, if you take a closer look, the carpal bones are appearing crowded here because there is joint space loss. Remember, the intercarpal joint space is lost. So this is how you identify an inflammatory joint disease. This is an X-ray of rheumatoid arthritis. This is an X-ray of rheumatoid arthritis. Everybody clear? Okay, very good. So once you are clear between, so now if you notice, I have shown you three arthritis so far. We said rheumatoid, osteoarthritis, tubercular arthritis, which are the more common things that you will see in your clinics. Now what I'll do is I will ask you another question based on a common condition that you will encounter. Okay, now you have to answer this question. Old man on X-ray shows, okay, a joint in which the articular margin, the joint margins have increased density and there are debris in the joint. Now, if I say increased density and debris in the joint, बेटा उदित भट्टागर, why you are not able to understand? I said ना, फेमिस्टर ने tuberculosis में बताया तो उसको वहीं बोलेंगे, है ना? Why would you call it in rheumatoid? ना, you understand? फेमिस्टर ने टीबी में बताया था, मैंने उसका कॉन्सेप्ट आपको समझाया कि रूमेटॉइड और उसमें सिमिलैरिटी इन्फ्लामेशन के कारण है, बट नाम थोड़ी हम हर जगह इस्तेमाल कर लेंगे. डू यू अंडरस्टैंड माय प्रॉब्लम हियर? उदित, डू यू अंडरस्टैंड दिस? भाई जो वो तो चला गया ना बता के, फेमिस्टर ने बताया टीबी में आर्थराइटिस में ये फाइंडिंग होती है, सो वी कॉल इट फेमिस्टर्स ट्रायड ऑफ ट्यूबरक्लोसिस. ओके, एवरीबॉडी अंडरस्टैंड्स? ओके, नाउ लेट्स सी इफ यू कैन अंडरस्टैंड. So an old man on X-ray of the joint shows, beta socho, increased density of the joint and debris. Now you need to tell me, is this wear and tear or is this an inflammatory disease? सोच के बताना है. Okay, do you think this is a wear and tear disease or an inflammatory disease? क्या लगता है? So when we look at increased density and debris, it looks like a wear and tear disorder. Inflammation होता तो osteoporosis होता. Everybody understands? Inflammation होता तो osteoporosis होता. Now we have wear and tear. Now please understand. Okay. Now in addition to this, I am also writing there is increased density debris. Now I'm saying there is dislocation of the joint. The joint is also appearing disorganized and it is appearing distended. ठीक है, अभी तक की बात से हमें लग रहा था there is some wear and tear of the joint happening. Now please look at the next two words. The joint is dislocated, disorganized, distended. क्या लगता है? लगता है बहुत ज्यादा wear and tear हो गया है. इतना ज्यादा wear and tear है, there is exaggerated wear and tear, that the joint is not only wear and tear, the joint is also become dislocated, disorganized, distended. So this old man on X-ray has increased density, debris, dislocation, disorganization, distension, which represent in my mind exaggerated wear and tear. Now, why would you have so much wear and tear? So much wear and tear in the joint can be explained by repeated trauma. This man must be having repeated trauma to the joint. Okay, उसको बार बार चोट लग रही है. Okay, but my question is, let's see if you can answer. उसको बार बार चोट लग रही है तो अपने आप को बचा क्यों नहीं रहा? If he is having repeated trauma, then why is he not saving himself? Because he has no sensation. उसको sensation ही, वो diabetic है. This is what is called as neuropathic joint, described by Charcot. So we give him respect by calling them as Charcot's joints, typically seen in people with diabetes. Okay, let me write it in full, otherwise you will get confused. Okay, so now you can understand with me that why do you have these findings in Charcot's joint. But now see the way in medical college how children are studying is, children are studying Charcot joint on X-ray shows 5 Ds, 5 bar D, density, debris, dislocation, disorganization, distension. But what happens in the real life is, उसको कभी समझ में भी नहीं आता है और वो रटता रहता है डी डी, एग्जाम में सब डी 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 हो जाता है. You understand this or not? So the key is not in mnemonics. Okay, मैं ये कह रहा हूँ, if you notice in my class, I will never tell you any mnemonic. I will only tell you how and why behind things. I will not talk about mnemonics because I don't believe that mnemonics are थोड़ा बहुत ठीक है. So what I believe is, to make a shortcut like a mnemonic should be like a salad or a pickle in the meal. It cannot be the main course. Do you agree कि नहीं? थोड़ा निमोनिक बनाया अचार की तरह तो ठीक है, लेकिन पूरा खाना ही अचार बना दिया, फिर क्या? So do you think becoming a doctor is making mnemonics? So do you agree or not? So please understand that your goal should be to understand, not to memorize. Okay, once you start understanding, you start enjoying. है ना? मजा ही तब आता है जब आप समझ पाओ या आपको कोई समझ पाए. Do you understand the concept? Okay, so now you understand. Now I'm repeating now. Charcot's joint is nothing but exaggerated wear and tear that happens in diabetics because of neuropathic loss of sensation in the joint. It is characterized by increase in the density of the surface, debris, dislocations, disorganization, distension. Okay, now one more question for you. Let's see if you can answer this. This is a tough question. Suppose you see deformity in a joint clinically, but when you do a X-ray, there are no erosions visible. What will you think? Can it be, suppose you see a X-ray of a patient where the hand is deformed like this. Okay, suppose you see X-ray of a patient where hand is deformed like this. Okay, is this rheumatoid arthritis or not? Yes or no? You have deformity, but you don't have erosions. Okay, if you have deformity but you don't have erosions, it is not rheumatoid arthritis. क्योंकि rheumatoid में तो पहले erosion थी, फिर joint space loss था, and then you had deformities. Here you have deformity but no erosion. That means this deformity in this patient is not because of the joint getting destroyed, it is because of some tendon and muscles having a problem. So you see such appearance in patients with lupus, SLE, and you also see such appearance in Jacquard's arthropathy. Okay, everybody clear? So I've just given you an overview on how to think when you are looking at a X-ray. Okay, how to think when you're looking at an X-ray. So if we have deformity but no erosions, that deformity might look like rheumatoid, but if there are no erosions, this is not rheumatoid. Because in rheumatoid, erosions happen first and then later on the deformity is there. So then we think of SLE and Trichard orthopathy. Everybody understands? Okay. Now, once you are clear, may I ask you now one more question? Let's see if you can answer. Can you tell one seronegative spondyloarthropathy which is HLA-B27 positive? Can you name one seronegative? Seronegative मतलब rheumatoid factor negative है वहां पे, लेकिन HLA-B27 positive spine को involve कर रहा है. So that is a typical example here is ankylosing spondylitis. So once we look at ankspons, then the common things that you need to know in an X-ray are done. Very often they will ask you this in the exam beta, so you cannot miss out on this. So are you clear? So tomorrow's gynae class will start at 2:30 p.m. 2:30 p.m. Beta, some of you are asking 2:30. Okay. Now let's see if you can answer beta. Okay. Ankylosing spondylitis is HLA-B27 positive spondyloarthropathy. What is the where will you see, in which joint will you see the earliest findings of ankspons? In which joint will you see earliest findings of ankylosing spondylitis? That is sacroiliac joint. So you will see sacroiliitis. Okay. Earliest thing that will happen in a joint in ankylosing spondylitis will be sacroiliitis. Okay. Now let's see if you can answer better. Any one of you can answer. I will ask anyone. In ankspons, the sacroiliitis will be unilateral, bilateral. It will be bilaterally symmetrical. Because we are looking at a systemic disorder, it tends to be bilaterally symmetric. Okay, sacroiliitis. But the key word I want you to remember is this sacroiliitis in ankspons is seen on MRI before you see it on X-ray. That is why we believe MRI is the IOC here. MRI will show you sacroiliitis early because you will see bone marrow edema around the SI joint, especially when you do fat suppression with a technique called a stir. Is any of you able to understand? Are you able to recall? I told you bone में inflammation होगी तो bone marrow में edema होगा. To see that, we need to suppress the fat by a technique called a stir. So I am sure now you are able to follow कि X-ray क्यों नहीं? Because X-ray cannot pick up ankylosing spondylitis early. That is why you see people in your hospitals advising MRI for ankylosing spondylitis. Okay. Okay. Second question, beta. Let's see if you can answer, beta. Okay. Any one of you can answer this question. Okay. I'm asking you a question, beta. Let's see. Okay. Everybody understands? Let's see. So now, what will you see on an X-ray first? This was a question which was asked in NEET PG 2019. What will be the X-ray feature? So on X-ray, ankylosing spondylitis will show. This was the answer in NEET PG 2019. Blurring of the subchondral cortex on the iliac side of SI joint. The key word to remember here is iliac side. Okay. Now that means if this is your sacrum and this is your ilium, okay. So SI joint has two sides, one sacral side, one iliac side. Okay, so okay, and Mayuresh Dhane, you have asked a very good question, Mayuresh. So even in rheumatoid, MRI will be able to show you changes in the hand before a X-ray does. Okay, that is true even for MRI today, even for RA also. But you have asked a good question. Inflammation देखनी है तो MRI bone में X-ray से पहले दिखा पाएगा, which is true everywhere. Now see, so now you might be thinking why it is seen more on the iliac side. Now, this is how the cartilage of the SI joint is in anatomy. Okay, I hope you have me back now. Let's see if you have me back. Let me just quickly, I don't know why today the internet is creating a lot of issue. Okay, now see. But it is good that it happens. It happened in my class also. Otherwise, Deepthi would have a conspiracy theory. Okay, so let's see now. So what I said is that the cartilage on the iliac side is thinner than the sacral side. Okay, the cartilage. You have me back now. Let's see. Okay, so what happens is because of inflammation that happens in this disease. Okay, so the iliac side starts to have erosions. Okay, I think the internet is now back, and let me just shift back from my phone to the internet Wi-Fi. Okay, I've just reconnected the normal internet. So let's see. So because of inflammation, the iliac sides gets involved. Then you develop, because of inflammation, you develop erosions. Inflammation causes erosions. So in ankylosing spondylitis, you will have erosions in the SI joint. But the strange thing that happens in ankspons is not only do you see erosions, okay, not only do you see erosions, along with erosions, you also have sclerosis. Now you need to tell me, in rheumatoid, we only had erosions. In ankylosing spondylitis, we have erosions with sclerosis. Can you think of a reason and tell me why it is happening? Now, we never had sclerosis in ankspons. Why do we have sclerosis we never had sclerosis in rheumatoid arthritis. Why do you have in ankspons? Because ankylosing spondylitis is a subacute inflammatory disorder. In subacute diseases, the evidence of destruction and healing go hand in hand. Remember, we talked about this in the last class also. Erosion मतलब destroy हो रहा है, sclerosis मतलब heal हो रहा है, दोनों एक साथ हो रहा है because angstpont is subacute. This is what leads to pseudo widening of the joint space. It is not the joint which is widened. The joint is actually destroyed by the erosions, leading to an apparent appearance of widening. We call it pseudo widening. And ultimately, the joint becomes fused because this is the nature of the disease. We call it ankylosis. Okay. So what are the X-ray features of rheumatoid arthritis and what are the X-ray features of ankylosing spondylitis? Ankylosing spondylitis begins with sacroiliitis, which is seen on MRI. Earliest on X-ray, you can only appreciate blurring of the subchondral cortex on the iliac side. Then you have erosions in the SI joint along with sclerosis because of the subacute nature. Then you have pseudo widening of the SI joint. Then you have ankylosis. Okay. Now, once you are clear. Now, what will happen in the spine? This is in the SI joint. Ankylosing spondylitis leads to enthesitis. What is enthesis? Enthesis is the insertion site. Okay, in the bone, wherever a tendon or ligament is inserted is called as enthesis. Itis is inflammation. Okay, this is something that you never saw in rheumatoid arthritis. Rheumatoid में नहीं था, ankspons में होता है enthesitis. Okay. Okay. Pseudo widening, I said, because that was not a true widening of the joint. Joint नहीं widen हुआ था, joint destroy हुआ था. But on the X-ray, it looks like widening, so we call it pseudo widening. Now let's see if you can answer. If these are your vertebra, okay, in between the vertebra we have the intervertebral disc. In between the vertebra we have the intervertebral disc. The central part of the intervertebral disc is nucleus pulposus, which is a notochord remnant, and peripheral part is all fibrous annulus fibrosus. Okay. Now, please listen to me carefully. It is just to listen, otherwise, you will miss the bus. Please listen to me. The outermost disc fibers are inserted in the vertebral corners. Outermost disc fibers are inserted in the vertebral corners. So, in acute stage, this will cause inflammation and destruction of the corners. भाई कहीं पे भी कोई फाइबर इंसर्ट हुआ, टेक्निकली दैट इज अ एंथिसिस. So vertebral corners are actually a enthesis on which the outermost disc fibers are inserted. So you will have vertebral corners in ankylosing spondylitis show erosions. These are called as Romanus lesion. These are called as Romanus lesion. Okay. So try and understand, otherwise you will keep mugging up and this is very difficult. Are you clear? But because ankylosing spondylitis is a subacute disorder, along with erosion, you will also have sclerosis. So the corners will also have accompanying sclerosis, which is called as shiny corner sign. And those of you who might have given the 2019 NEET exam, this was the question asked in the NEET exam. Are you clear? So ankylosing spondylitis will also involve the spine. In spine, there will be corner erosion along with corner sclerosis. Erosion is called as Romanus lesion. Sclerosis is called as shiny corner sign. Okay, now see if you can answer. What will happen when there is long term, when it is chronic disorder? What will happen then? Initially, there will be inflammation, but what will happen later on? Later on, what will happen is you will start to develop chronic inflammation. Chronic inflammation will lead to some healing, some fibrosis. Now, what will happen is the outer disc fibers will become ossified. Okay. In chronic stages, in ankylosing spondylitis, the outer disc fibers, they become mineralized to form what is called as syndesmophytes. Okay. Now, any one of you, please see this X-ray and tell me. Okay. Okay. And any one of you and tell me and think of it and answer. ये क्या बन जाएगा? This is what is called as bamboo spine. Okay, now are you clear? This is what you might have studied or heard of in your pathology and other subjects. This is what is called bamboo spine, syndesmophyte. Not only this, if these are your spinous processes, at your spinous processes, we again have an enthesis. Spinous process is an enthesis because the interspinous ligament is inserted onto it. And when it is long standing, the interspinous ligament becomes ossified, and which is called as dagger sign. Are you able to follow the points? Are you able to understand the concept? Okay, so ankylosing spondylitis is difficult disease. That is why most people in your medical school will not tell you. Try and understand. The difference is many people, they try to please the students. They try to please the students by teaching them what they can understand and not teaching you what you cannot understand. Okay, so then what will happen? You will be happy, but long-term success will not come. To give you long-term success, we have to explain to you tough concepts. Okay, so are you clear with this or not? Ankylosing spondylitis will lead to enthesitis, which will lead to erosion of the vertebral corners. Because it is subacute, you will also have sclerosis. So we have two words, Romanus lesion, shiny corner sign. ओके, ये हड्डी में हुआ, लेकिन बाद में जो लिगामेंट थे वो धीरे धीरे कैल्सिफाई होते जाएंगे क्योंकि पुरानी होगी बीमारी. एंड दैट इज व्हाई यू हैव बैम्बू स्पाइन एंड यू हैव इंटरस्पाइनस लिगामेंट ऑसिफिकेशन कॉल्ड एज डैगर साइन. Now let's, both we have seen it theoretically. Now let's see it practically. Okay, I will now take you back to the practical of it. Now please look at the X-ray together. Now, are you able to see in this X-ray, which is very important X-ray, you cannot do it wrong. Can you see outermost disc fibers? Outermost disc fibers are ossified. These are syndesmophytes. Can you see the origin of the word bamboo? It is looking like a bamboo. So we say bamboo spine. Can you see them now? Clear, angsponds? And not only that, the interspinous ligament is also ossified, which is called as the dagger sign. Okay, are you clear? Everybody able to understand this? Okay, so this is what is called as bamboo spine. Every year they will show you this picture in the exam. You do it wrong, then you will have to come back and sit on this class again. You cannot do bamboo spine wrong in the exam. Seen in ankylosing spondylitis. When you look at angsponds on the lateral view, if you see angsponds on the lateral view, again if you get confused, just see this. There will be vertebral corners will be joined together by syndesmophytes. Okay, are you able to see there is a bony bridge which is representing the ossification of the outer disc fiber, which is joining the vertebra together? Can you see that? So when you see this, you will call it angsponds. Another thing to remember here is squaring of vertebra. Another thing to remember here is squaring of the vertebra. Because of the corner erosions, the vertebra will become square in shape, and even on a lateral view, you will see syndesmophytes. Even this is ankylosing spondylitis. Everybody clear? Okay. Now let's see and answer one more question. Okay. Once you are clear, also remember people with ankylosing spondylitis have a rigid, stiff spine. Do you agree? अगर वर्टेब्रा आपस में जुड़ गए तो the spine will become rigid, it will become stiff. So anything which is stiff, it fractures easily. Spine in ankylosing spondylitis can fracture after minor injury. So now this is why what happens here is, listen to me and understand. So that is why ankylosing spondylitis, sometimes the patient after an injury may develop a fracture of the spinous entire vertebral column through and through, as if somebody has broken a carrot. It is complete breakage of the entire vertebral column. That is what is called as carrot stick fracture. So in ankylosing spondylitis, you will see carrot stick fracture. Now please see, बेटा पिक्चर फ्रेम बाद में आएगा बेटा, डोंट रन बेटा, भाग रहे हो, मैं दिखाऊंगा पिक्चर फ्रेम. स्क्वेयरिंग ऑफ वर्टेब्रा इज एंकिलोजिंग स्पॉन्डिलाइटिस. पिक्चर फ्रेम बाद में आएगी, पिक्चर बाद में आएगी. ठीक है, आर यू क्लियर? ओके, नाउ लेट्स सी एंड अंडरस्टैंड. स्क्वेयरिंग क्यों हुई? सम ऑफ यू आर आस्किंग. बेटा ट्राई एंड अंडरस्टैंड. इफ दीज आर योर वर्टेब्रा, दीज आर योर कॉर्नर्स, अगर कॉर्नर इरोड हो गए, इफ देयर इज कॉर्नर इरोजन, तो वर्टेब्रा ऐसे हो जाएंगे. Do you understand this? It is because of the corners getting eroded because of inflammation, the vertebra becomes square in shape. Okay. Now what happens in AIMS is, in this year in AIMS exam, this is an X-ray from June 2020 AIMS, straight away asked from our workbook, and you can see this workbook was printed before that. Okay, we could not have printed it in June 2020 because of the pandemic. So we have already given you this, and you can see the prediction that we have. So in this year's AIMS exam, they gave a picture like this. Can you see there is ossification here? Look at this part. Okay, what structure is this? What structure is this? Anybody? This is your anterior longitudinal ligament. This is not syndesmophyte. Syndesmophyte तो पतले से थे ना, outer disc fiber की, ये तो मोटा सा है. So what is this? This is ossification of, this is flowing wax ossification of anterior longitudinal ligament. So everybody got it wrong other than our students in this year's AIMS exam. Any one of you can tell me, is this ankylosing spondylitis? No, this is not ankylosing spondylitis. उसमें तो syndesmophyte होते हैं. ये क्या है? This is a disease which is called as dish. This is a disease which is called as dish. What is dish? Dish is diffuse idiopathic skeletal hyperosteosis. What is this? Diffuse idiopathic skeletal hyperosteosis, also called as Forestier's disease, after the name of the person who described, also called as Forestier's disease. Now, difference between DISH and Angstpon's is, DISH is a non-inflammatory disease. Ankylosing spondylitis was an inflammatory disease. This is non-inflammatory. SI joints in DISH are normal. Please put a star here. There is no sacroiliitis in DISH. And DISH most commonly involves the thoracic spine. And in thoracic spine, there is asymmetry. Right side is involved more than the left. Okay, so this is where now you can see how the AIMS people confuse the children. They showed a X-ray. It looked like bamboo, but it is not bamboo. You understand? In bamboo spine, it is the outermost disc fibers which are ossified to form bamboo spine. This is flowing wax ossification of anterior longitudinal ligament, and the answer to the question was dish. So that is why you need to remember 3 words for your future exams like AIMS. It is not an inflammatory disorder. There is no sacroiliitis. Most common part of the spine is thoracic spine. Okay, everybody understands? Okay. Can anybody now understand? Let's see. Let's try to be together here and let's try to understand. Now, suppose you have some uric acid crystals deposited in your soft tissue. Can you see it here? So can you see around the first metatarsophalangeal joint? In this X-ray, you can see there is some soft tissue swelling. That is because of the uric acid tophi. Now these uric acid crystal, can you think of them? Oh, hard honge. They will cause some pressure erosions on the underlying bone. थोड़ा inflammation भी करेंगे, but थोड़ा okay. Am I back? Okay, so I think I'm back now, huh? So in between, I think I clicked the button by mistake. Okay, so again, now if you notice in this patient's X-ray of the foot, you have some soft tissue which is because of uric acid that's causing pressure erosion. Can you imagine now? ये हड्डी है आपकी, यहाँ पे crystals हैं. ये crystal के रगड़ के कारण, because of the pressure, the bone is eroded. These are called as rat bite erosions, or we call it punched out erosions. And the key is they are away from the articular surface. ये erosions देखो, ये जो joint है ना, joint ये वाला इससे थोड़ा दूर है. So they are away from the articular surface. What do you think we are looking at? We are looking at X-ray of gout. So this is how you identify gout in the exam. But did I tell you gout somewhere else as well? I told you today there is a role of a new CT technology called as dual energy CT to identify uric acid deposits in gout. Okay, MTP मतलब बेटा metatarsophalangeal joint. अभी गायनी का क्लास हुआ ना, तो you're thinking of medical termination of pregnancy. But in the foot bones, there is no pregnancy possible. Okay, ectopic इतनी दूर तक नहीं आएगा बेटा. Okay, everybody understands? Okay, now see in the next picture and answer. Now see, this is a potential aims picture again for you. Let's see, any one of you can tell me this is a potential aims question in front of you now. Next time they will ask you this, okay? Then don't come and tell me that aapne dhyan nahi diya. Please see. What is this? This is a X-ray of the spine, lateral view. Can you see these white areas? What is this? The disc. So why is the disc appearing white? The intervertebral disc is calcified. Okay. Any one of you can answer, beta. Any one of you can answer. Name a condition in which intervertebral disc is calcified. Name a condition in which intervertebral disc is calcified. Okay. So the answer here is very important question. Why am I saying aims? Is because it is integrated. Integrated kyun? Because the answer is not in your radiology and pathology. It is in your biochemistry. It is alkaptonuria. Ochronosis. You remember this or not? Did you read this or not? So that in cartilage gets calcified in alkaptonuria and ochronosis because of yellowish pigment deposit in the cartilage. Remember that? Homogenetic acid oxidase deficiency. Did you read this or not? Alkaptonuria is a classic cause of disc calcification. Okay. Name one more condition in which you have cartilage calcification. Name one more condition in which you have cartilage calcification. Cartilage calcification is called as chondrocalcinosis. So if they say chondrocalcinosis ever in your exam, please also think of one more condition which is called as pseudo gout, which is nothing but CPPD deposit, calcium pyrophosphate deposit. Okay, are you clear with this or not? Are you able to understand this? So chondrocalcinosis is a feature of pseudo gout, which is nothing but calcium pyrophosphate deposit. Okay, while alkaptonuria will have disc calcification basically. Okay, now let's see if you can answer. Okay, now we come to the miscellaneous. Okay, so we have seen some joint disorders. I've shown you the most common ones. Now I will show you some miscellaneous. Okay, miscellaneous. I want to talk about a disease which begins with osteoclastic activity. That means there is destruction of the bone. Then what happens is osteoblasts become mad. Osteoblast पागल हो जाते हैं, leading to chaotic mosaic bone formation. Can you guess the disease that I'm trying to build up? Can you think of a miscellaneous bone disease in which you have osteoclastic activity followed by mad disorganized osteoblastic activity, which is chaotic, leading to mosaic bone formation, that is called as the Paget's disease of the bone? What is Paget's disease? Osteoblasts ka pagalpan is Paget's disease. Now what will happen in Paget's disease is the disease will begin by, so initially when you look at the skull X-ray in a patient with Paget's, you will see a single large lytic lesion in the skull. Okay. In Paget's disease, initially you will see a single large lytic lesion in the skull, which is called as, okay, you will read this with Dr. Tushar also maybe, osteoporosis circumscripta. Okay, are you clear? Osteoporosis circumscripta. In which condition do we see osteoporosis circumscripta? It is a large destructive lytic lesion in the skull seen in Paget's disease. Later on, what will happen? Later on, the osteoblast will become mad. Osteoblast पागल हो जाएंगे और जहां मन करेगा बोन बनाना शुरू कर देंगे. So can you see, because of this random osteoblastic activity, there are white areas in your skull? This is what is called as cotton wool skull. And I'm sure you are aware of it. It's a very characteristic MCQ, very often asked. Cotton wool skull seen in Paget's disease. Cotton wool skull seen in Paget's disease. Okay? Okay, Paget's disease of breast alag tha beta. Soumya, that was different. Okay, well, this is different. Okay, there is only the person is same who described. The diseases are different. Okay, and then what happens in Paget's, because of osteoblastic activity, the vertebra enlarges. सोचो अगर बोन बन रही है तो वर्टेब्रा बड़ा हो जाएगा. Okay, and not only it enlarges, it starts to show increased density along all the borders of the bone. Can you see there is increased density there is sclerosis, there is remodeling along all the borders of the vertebra. This is what is called as picture frame vertebra. This is what is called as picture frame vertebra. Okay, so there are two classic words that I want everybody to know at least: cotton wool skull, picture frame vertebra, seen in Paget's disease of the bone. And also because of osteoblastic activity, even your skull will become elongated. Even your skull will become elongated, and the frontal part starts to elongate more. It becomes longer than your face. So it is like this. It is like this cap that you see here. This cap is called as tam o'shanter. So that is why this appearance is called as tam o'shanter skull. What is tam o'shanter? Tam o'shanter is a Scottish cap which this man is wearing. So tam o'shanter skull is seen in Paget's disease. Are you clear with this much? Easy. So in this page, the only three pictures that I've shown you were pictures of Paget's disease. Let's see if you can answer one more question. Now please look at the next X-ray and tell me, is this picture frame vertebra? Is this picture frame vertebra? Okay. Is this picture frame vertebra? No, this is not picture frame vertebra. Why? Because only the superior and inferior borders of the vertebra are dense, not the entire vertebra. Now in America, when they play American football, listen to me everybody, in America when they play American football, okay, whenever they are playing American football, they wear a jersey. This jersey is like this. Okay, so in America, when they play American football, they wear a jersey which is like this. So American football is called as rugger, jersey is jersey. So this appearance is called as rugger jersey spine. Rugger jersey spine is seen in patients with chronic renal failure. So this is what we will call it as renal osteodystrophy. But I'm sure many of you are able to appreciate, इसमें चारों तरफ dense नहीं था, सिर्फ ऊपर और नीचे dense था, renal osteodystrophy. Only one word I'm wanting you to remember, because CRF you will study in your nephrology class, you might have studied in detail. It is because of secondary hyperparathyroidism happening in CRF. Just remember this, because I cannot go into CRF metabolism that you will study in nephrology, but just remember it is because of secondary hyperparathyroidism in renal failure. Okay, can you name any other cause of rugger jersey spine? Rugger jersey spine is also known to occur in a condition called as osteopetrosis. Rugger jersey spine is also known to occur in osteopetrosis. What is osteopetrosis? Marble bone disease, which is a problem in osteoclasts. You remember, an osteoclast function abnormality called as osteopetrosis. But the most characteristic X-ray appearance of osteopetrosis is this. Most characteristic appearance of osteopetrosis is this. Any one of you can answer better. Okay, what do you see inside this vertebra? So we can see there is problem in osteoclast. So the bone is not getting destroyed, but the new bone is forming. So you are seeing a bone forming within the bone. So we'll call it bone within bone appearance. So characteristic X-ray feature that you see in osteopetrosis is bone within bone appearance. But do not forget the Rugger Jersey spine is also possible in osteopetrosis. Okay. And another thing to remember here is if these are your bone, if this is your femur, in osteopetrosis, the cortex of the bone will get thickened. And when the cortex is thickened, the medulla gets obliterated. When the medulla is obliterated, the body tries to compensate by increasing the size of the lower end of the femur because you need bone marrow. So the lower end of the femur is expanded. This is called as Erlenmeyer flask femur. Are you able to understand my point? Is it making sense to you that the cortex is thickened in this disease, the medullary canal gets obliterated, so the lower end becomes widened to compensate. That is called as Erlenmeyer flask femur. Same appearance is also seen in hemophilia. Why? Because even in hemophilia, the bone marrow is expanding. That leads to Erlenmeyer flask femur even in hemophilia also, because both of them will have bone marrow expansion. Everybody follows? Okay. Now, final miscellaneous picture, and one after this miscellaneous picture, we will start with ultrasound. Okay, just one, little bit ultrasound will cover. Rest of it will cover in the next class. But let's, see anybody. Okay, anybody. What do you see here? So now in this X-ray of a child, you can see fractures, 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 fractures. So there are multiple fractures in the bone, but some of the fractures are showing healing. If you notice, here you can see some callus formation. Okay, here you can see some callus formation. Now I'm sure some of you will be able to answer. This patient has multiple diaphyseal fractures, okay, in different stages of healing. What do you think we are dealing with? We are dealing with osteogenesis imperfecta. Multiple diaphyseal fractures in different stages of healing is seen in osteogenesis imperfecta. May I ask you a question? Why this is not battered baby syndrome? Why this is not battered baby syndrome? So in battered baby, the fractures are not diaphyseal, the fractures are metaphyseal. Okay. In battered baby, the fractures, they look like this. Okay, so you have a metaphyseal corner fracture. Or we can say sometimes entire metaphysis will be having a thin fracture like this, metaphyseal bucket handle fracture. So are you clear with this or not? Battered baby will have metaphyseal fractures, which will be typically in the corner or shaped like a bucket handle, while the diaphyseal fractures in different stages of healing, think of osteogenesis imperfecta. Any other finding of OI that we discussed already? Another finding to remember is Wormian bones. In the lamboid suture of the skull, you will see multiple sutural bones. Can you name any other condition in which I told you Wormian bones? I told you Wormian bones in hypothyroidism. Don't forget rickets and even in Down syndrome. Okay. Wormian bones on X-ray are seen in osteogenesis imperfecta. OI matlab osteogenesis imperfecta. Okay. Hypothyroidism, rickets, and Downs. Just to make a note here, in Down syndrome on X-ray, you will see, okay, we talked about Vermeer bones. Any other thing you might know that you can see in Down syndrome? Atlantoaxial dislocation. So Down syndrome is one of the causes of atlantoaxial dislocation. Remember, even in rheumatoid arthritis, you have atlantoaxial dislocation because of inflammation. Also remember, in Down syndrome, you have 11 pair of ribs. And you have a finger deformity called as clinodactyly. Okay, so in Down syndrome, you have absent nasal bones as well. Okay, everybody clear? So Down syndrome, what are the X-ray features? Vermeer bones. Okay, atlantoaxial dislocation. AAD क्या है? AAD क्या है? Atlantoaxial dislocation. लेकिन भूलना नहीं, atlantoaxial dislocation rheumatoid में भी होता है बेटा, भूलना नहीं. 11 pair of ribs, clinodactyly, absence of nasal bones. Okay, clear? वेरी गुड. AAD मतलब एटलांटो, मैं लिख देता हूं बेटा, नहीं तो आप बार बार पूछते रहेंगे. एटलांटो एक्सियल, यानी एटलांटो माने C1, एक्सियल माने C2, डिसलोकेशन. Okay, so with this, we have finished with the things that I wanted to teach you in bony x-rays, which are typically seen as a question in the exam. Now I will initiate a bit of ultrasound with you today. Okay, very little bit of it, but we'll try to cover some ground here, and let's try to understand a little bit about ultrasound. Okay, ultrasound images are less. Ultrasound images in the exam are less, but I will show you some very characteristic images for you. Okay, very characteristic images. Let's see if you can answer. Ultrasound is based on a principle called as piezoelectric effect. Okay, any one of you can see this question in your exams. Ultrasound is based on a principle called as, okay, I'm going slow, piezoelectric effect. Okay, so ultrasound crystals are made up of PZT, which is actually a combination of lead, zirconium, titanium. So suppose this is your ultrasound probe. In your ultrasound probe, you have a crystal made up of PZT. This crystal has a property: whenever you apply electrical current to it, it vibrates and produces sound. Okay, everybody, ultrasound machines are based on a principle called as piezoelectric effect. These crystals are made up of PZT. These crystals are made up of PZT. Whenever you apply electrical current to these crystals, they produce sound. Okay, this is the basic. This is the basic philosophy behind the ultrasound. Now, how does this machine work? I will explain to you with example. Now, what is happening is, suppose this is your ultrasound probe. This is the ultrasound crystal. This crystal has a thickness of T. Okay. Any ultrasound, okay, listen to me everybody, any ultrasound machine which has a thickness of T will produce sound which has wavelength of, okay, little bit physics, don't panic beta. Wavelength is written as lambda if you remember from school beta. Wavelength of 2 into T. Okay. So ultrasound machine has a crystal with thickness of T. So the sound produced by this machine will be having wavelength 2 into T. Okay. And remember, what will be the velocity of the sound produced? Sound produced will have a velocity dependent on the medium. So can anybody tell me what is the velocity of sound in air? Velocity of sound in air was 330 meter per second. You remember this from school and your PMT times? But velocity in human body you do not know. You have to remember with me. Velocity of sound in human body is 1540 meter per second. Okay. Okay, it's just a little bit of one physics equation I'm trying to develop. Okay, so I'm going a little fast here. Don't worry, just one line I want to teach here. Okay, if velocity is written as c, and you already know it, don't worry, you know it from your school. And wavelength is written as lambda. C by lambda is equal to mu. What is mu? Frequency. So that means I can derive frequency of sound produced by an ultrasound machine is actually 1540 divided by 2 into T. Okay. Okay, everybody follows? Are you able to derive this complicated equation now? Okay, I'm repeating everybody. Okay, so now try and understand. Okay, wavelength of sound produced by ultrasound is twice the thickness of the crystal in the machine. Velocity in human body is 1540 meter per second. So frequency will be 1540 divided by 2 into T. So reason I'm telling you this is because see a previous JIPMER MCQ, they've asked frequency of sound produced in an ultrasound machine is inversely proportional to thickness of the crystal used. Is it true or false? Frequency of ultrasound produced by an ultrasound machine is inversely proportional to thickness of the crystal. That is correct. Now do you understand why we have different ultrasound probes? You might have seen in the ultrasound machine, we have different probes. All of them have different thickness. So all of them produce different frequency of sound. Okay. Okay, some of them you are loving frequency. So can you see this school class 10th equation? So that's why I was going a little fast. This is nothing to do with medicine. This is just a school thing. Yeah, they can C by lambda is mu. You remember? Okay, some of you remember, some of you forgotten. Now do you understand anything that you study with your heart stays with you? जिन्होंने समझा था दिल से पढ़ रहे थे उनको याद है, जो उस समय रट रट के फिजिक्स को निकाल रहे थे एग्जाम के लिए, they have forgotten. Okay, so this is same thing would happen in medical college also. Anything that you study with your heart will stay with you. Now why this frequency is so important? Frequency of sound in ultrasound machine is directly proportional to image resolution. मतलब डायरेक्ट प्रोपोर्शनल का मतलब होता है, सोचो, बोलो, जितना ज्यादा फ्रीक्वेंसी उतना ज्यादा रेजोल्यूशन. उतने रेजोल्यूशन का मतलब है छोटी चीज को देख पाना. रेजोल्यूशन मींस एबिलिटी टू सी स्मॉल ऑब्जेक्ट्स. So frequency is directly proportional to image resolution. But the problem is in ultrasound is it is inversely proportional to depth penetration. This is the basic principle of ultrasound physics that you need to know. Okay, ये सबको पता होना चाहिए. This will have a lot of clinical implications. More the frequency, better is the resolution, but less is the penetration. Okay, so this is the trade-off between whenever we are doing an ultrasound. This is the trade-off. Let's try to understand the concept now. Okay, Let's try to understand the concept better. Please notice with me. बेटा अभी कुछ भी सुबह भी नहीं हुई, अभी तो ऐसा ही है, कुछ भी नहीं है, रिलैक्स है. So routine abdominal ultrasound or routine obstetric ultrasound have a frequency of 3.5 to 5.5 or 5 megahertz. ठीक है. सौम्या बेटा मेडिसिन भी रोट लर्निंग नहीं है बेटा, आपने उसको बनाया वैसे. इफ दिल से पढ़ोगे तो मेडिसिन फिजिक्स से भी ज्यादा कॉन्सेप्चुअल है बेटा. ओके ओके. नाउ लेट्स सी इफ यू कैन आंसर. So routine abdominal and obstetric ultrasound, the frequency of sound used is 3.5 to 5 megahertz. Hertz is a unit of frequency. But when you do a transvaginal ultrasound or transrectal ultrasound, okay, and I'm sure you read about transvaginal ultrasound in gynecology, transrectal ultrasound when they were talking about ejaculatory drugs, seminal vesicles, है ना. So trus or transvaginal ultrasound में frequency of sound is 5.5 to 7.5 megahertz. Okay, I will ask you to explain all this. And when you do ultrasound of a superficial organ like orbit, thyroid, scrotum, breast, these are called as superficial ultrasound. The frequency of sound used is 8 to 12 megahertz. And when we do endoscopic ultrasound, the frequency is 12 to 20 megahertz. Please explain all this to me. Based on the physics that we have learned, and we have learned some concept, tell me. जैसे जैसे we are taking the ultrasound machine closer to the organ, we are able to use higher frequency. Now are you clear? भाई TVS के अंदर हम क्योंकि यूट्रस के पास हैं, हमारा फ्रीक्वेंसी ज्यादा है. So that's why we get better resolution. Okay? Everybody understands? Okay, now everybody understands. So I will talk about Planck's constant later on. Some of you are asking, हम बात करेंगे उस बारे में. But let's see if you can answer. My question to you is this. Okay, okay. Let's see if you can understand and answer and explain a simple question. Earliest evidence of fetal life is seen on. Earliest evidence of fetal life is seen on transvaginal sonography. Tell me why. Why not routine ultrasound? भाई routine ultrasound में हमें frequency कम यूज कर रहे थे क्योंकि penetration चाहिए. But when you do a TVS, you are right next to the uterus with your ultrasound probe, and you able to use higher frequency. You get better resolution. Better resolution मतलब you can see gestational sac early. Are you clear? Everybody understands? Okay, once you're clear. Okay, second question. Let's see if you can answer the second question here. So that means frequency is the key word here. Okay, let's see if you can answer my question. हाँ? देखते हैं आप में से कौन बताता है. Okay. Now suppose this is a fluid-filled structure with thin walls. Let us call it cyst. A fluid-filled, thin-walled structure is called as cyst. Okay, let's see if you can answer. If I send sound through the cyst, what will happen? Water allows the sound to transmit. It does not reflect. समझ पा रहे मेरी बात को? वाटर साउंड को ट्रांसमिट करता है, रिफ्लेक्ट नहीं करता. Okay, now tell me, whatever sound I am sending into the cyst in the water is not reflected back. If the sound is not reflected back, will my machine receive any echoes? No, मेरी इस मशीन को कोई साउंड वापस मिलेगा ही नहीं. So that is why cyst on ultrasound appear black. We will call them anechoic. Are you clear? Are you able to understand my concept or not? Cysts are, because they fill up with clear water, they will be anechoic. Okay, now let's see if you can answer my question, beta. I'm sure some of you will be able to answer. Because the cyst is not reflecting any sound, so the amount of sound which is transmitted in the distal to the cyst is high. So there is increased through transmission of sound distal to the cyst. This is called as acoustic enhancement. Okay, so there is an increase through transmission distal to the cyst, through transmission of the sound distal to the cyst, which is called as acoustic enhancement. Okay, let's forget about it. Let's see the image and we'll come back with the image and understand with a practical image. Okay, now see this image with me. I will try to explain to you. Can you see a well-defined rounded anechoic structure? Yes. So this is what is called as anechoic. Now please see, the sound is coming from this direction. Everybody now stop wishing happy birthday to each other. Please wait and let me give you this concept here. Okay. Every night at this time, I start thinking that I should have a music with me which should say happy birthday. Next time I'll get a video. Okay. Now this is how the sound is going, beta. But this soft tissue are stopping the sound, but cyst is allowing the sound freely. So if you now notice, distal to the cyst, the area is appearing more white as compared to other areas. This is more white. This is called as acoustic enhancement. Any question which says two words, a lesion is anechoic, or in gynae you will read an ovarian cyst is anechoic with acoustic enhancement, think of cyst. Okay. Now anybody, if you can answer this, beta. Cysts are usually benign. This is the basic pathology principle. Cysts are usually benign, and if you see something solid, it is most likely to be a tumor. Solid things will be tumors, cyst will be benign. Only reason we will think of malignancy in a cyst will be if you have thick septae, solid components, or you have a mural nodule like we saw in brain in hemangioblastoma. Are you clear with these basic pathology principles or not? Solid lesions are usually tumors, cystic lesions are benign. And that is where, if you can now understand, all you third-year students also listening to me today, remember when you go to the surgery ward, they will tell you that if you keep your finger on a lump, you push with one finger, the other finger goes up, that is fluctuation. That tells you the lesion is cystic, and being cystic tells you that we are looking at something benign. Understand? भाई कोई lump है यानी body से कोई चीज बाहर आ रही है, that means it could be some growth, it could be a tumor, but cysts are benign. So that is why you do all this fluctuation and trans-illumination in your clinical examination. Reason I'm telling you all this is because I want you to be impressed by one line. Investigation of choice to differentiate a solid lump from a cystic lump always is ultrasound. Okay? Okay? कभी भी solid और cystic lesion को फर्क करना हो, हमेशा मार्क करें ultrasound. Are you clear with this or not? Cysts are usually benign, but exceptions are cyst with thick septa, cyst with solid components, cyst with mural nodule. ये cancer हो सकते हैं. Solid lumps are usually tumors. Everybody understands the concept? Okay. Now let's see the second concept. Suppose this is your gallbladder, है ना? और ये gallbladder में बेटा ये stone है. So I will call them gallstones. Suppose I send sound into the body, sound goes and strikes the gallstones, gets reflected back. Stones hard होने के कारण, all the sound which strikes the stone is reflected back. So what will happen? Too many echoes will come back to you. So gallstones on ultrasound will appear hyperechoic. They will appear white. Hyperechoic. Okay? Gallstones will be hyperechoic. Not only this, listen to me, everybody, listen to me. Not only this, distal to the stone, the sound will not be able to transmit. So you will see a dark area which is called as acoustic shadow. Everybody understands? So gallstones, this is how gallstones appear on an ultrasound. Let's try to understand this. Okay, beta? This is your gallbladder filled with bile. That is why it is appearing black. But in the dependent area, we can see something white. These are your stones. Hyperechoic. But can you guess what is this dark area behind it? This is what is called as acoustic shadow. This is called as acoustic shadow. Everybody understands? Okay. Now let's see if you can answer. Okay. Let's see how many of you are able to answer my question. Gallstones. Investigation of choice for a patient with gallstones is ultrasound. Investigation of choice for a patient with gallstones is ultrasound. You might ask me, sir, why not X-ray? Only 10% of the gallstones are radio opaque. सिर्फ 10% ही एक्सरे पे दिखेंगे, इसलिए अल्ट्रासाउंड इन्वेस्टिगेशन ऑफ चॉइस है. ओके, व्हाट इज द इन्वेस्टिगेशन ऑफ चॉइस फॉर एक्यूट कोलेसिस्टाइटिस? गॉल ब्लैडर में इंफ्लेमेशन हो गई, एक्यूट कोलेसिस्टाइटिस. व्हाट इज द इन्वेस्टिगेशन ऑफ चॉइस? अल्ट्रासाउंड. व्हाट आर द अल्ट्रासाउंड फाइंडिंग्स? Gallbladder wall will be thick and edematous, which is logical to believe. कहीं भी inflammation होगी तो सूजन होगी, edema होगा, and there will be probe tenderness. Which is called as sonographic Murphy's. Plus pericholecystic fluid. है ना, याद मत करना, सिर्फ समझ लो. कहीं भी इन्फ्लामेशन होती है यही होता है, इडीमा होगा, कैपिलरी लीक करेगी, थोड़ा फ्लूइड इकट्ठा हो जाएगा, और फिर वहां टेंडरनेस होगी. इन्फ्लामेशन का हॉलमार्क है एक्यूट इन्फ्लामेशन का पेन. सो यू विल हैव ऑल दोस थिंग्स. इन एक्यूट कोलेसिस्टाइटिस यू विल हैव जीबी वॉल थिकनिंग, इडीमा, probe tenderness, which is called as sonographic Murphy's sign, pericholecystic fluid. Everybody understands? Logical? Okay, what is acoustic shadow? अगर कोई भी चीज, बेटा सोच के बताना, कोई भी चीज साउंड को पूरी तरह रिफ्लेक्ट कर देगी तो उसके पीछे क्या आएगा? शैडो आएगी. यू अंडरस्टैंड दिस? लाइट के आगे अगर कोई चीज ऐसी आ जाए जो पूरी लाइट को रिफ्लेक्ट कर दे तो पीछे शैडो आती है. सो दैट इज व्हाई बिहाइंड द गॉलस्टोन्स we are able to see a dark area. This is, which I marked with yellow arrows, is called as acoustic shadow. Okay. Now the question number 3 is, let's see how many of you are able to answer my question. What will happen in chronic cholecystitis? Acute cholecystitis तो आपने बताया. What will happen in chronic cholecystitis? Chronic inflammation में हमेशा होता है fibrosis. So because of fibrosis, the gallbladder will become distended or contracted. It will become contracted, fibrosed. Okay? बेटा बस 2 इमेज हैं, उसके बाद ही जाऊंगा, चाहे बेटा आप टाइप करो कि नहीं करो. You understand? I have to finish this, बेटा. I have to finish the ultrasound here before, because next class में I want to start with Doppler. Okay, बेटा? Just 1 or 2 minutes है बेटा. I told you in the first class, don't be a clock gazer. घड़ी को देख के नहीं चलना हमने. जिंदगी घड़ी से नहीं चलेगी, है ना? So if these are gallstones and the gallbladder is contracted, fibrosed, what will happen? Now see with me. Now what will happen is, when you do an ultrasound, you will see the gallbladder wall. You will see echoes because of the stone. And then after the stones, you will see shadows. You will not see the gallbladder lumen, because the gallbladder lumen is contracted. प्रोब टेंडरनेस मतलब अल्ट्रासाउंड करते समय अगर प्रोब से दबाएंगे तो पेशेंट को टेंडरनेस लगेगी, ओके, उसको दर्द होगा, okay. Let's see and understand. I'll show you better, okay, I'll show you better. Please see with me. Now see in this patient, this is an ultrasound image showing you the gallbladder wall. This is the gallbladder wall, okay. This is your echos because of the stone, and then you see shadow behind it. This is what you might have studied in surgery as West triad. This is what you might have studied in surgery as West triad. Okay. Some of you are asking कि सर कोलेसिस्टाइटिस में एमआरआई क्यों नहीं? बेटा जब अल्ट्रासाउंड पे पता चल ही रहा है तो फिर एमआरआई तक क्यों जाए? Okay. Now let's see. Okay. Anybody. So gallbladder तो देख लेना बेटा, acute और chronic तो साथ में देखना पड़ेगा ना. So chronic cholecystitis, all you see is gallbladder wall with echos because of stones, and then distal shadow, which is called as West triad. West triad is seen in chronic cholecystitis with cholelithiasis. Everybody understands? Chronic cholecystitis with cholelithiasis, you will see West triad. Everybody understands? Okay. Okay, now let's see an answer. Now there is one condition that you might have studied in gynae also, but it happens in gallbladder also. If this is your gallbladder mucosa, columnar mucosa, in one condition the columnar mucosa outpouches into the muscularis. एक ऐसी बीमारी जिसमें कॉलमनर म्यूकोसा को मैं कह रहा हूं एडिनो, चला गया मसल में मैं कह रहा हूं मायोमटोसिस. Okay, so you can have adenomyomatosis of the gallbladder, and this outpouching of the mucosa is called as Rokitansky-Ashkoff sinus in pathology. Did you read this in pathology? कि gallbladder की mucosa का muscularis में जाना is adenomyomatosis, Rokitansky-Ashkoff sinus. But don't get confused. There is something else called as Rokitansky protuberance. वो क्या था? So Rokitansky protuberance you will study in dermoid. Dermoid में पाया जाता है Rokitansky protuberant. Okay. Now what happens is when sound strikes these Rokitansky sinus, part of sound is reflected, but part of sound is transmitted through it. Okay. Rokitansky sinus में जब भी sound टकराएगी, some sound will be reflected by it, some sound will be transmitted. So what happens is when you do an ultrasound, you will see from the gallbladder wall white tail-like things coming out, which is called as comet tail sign. So the only word I want you to remember, अगर gallbladder में, okay, अगर gallbladder में आपको white tails wall से निकलती हुई दिखेंगी, that is called as comet tail sign. Comet tail sign seen in adenomyomatosis of the gallbladder. Comet tail sign seen in adenomyomatosis of the gallbladder. And before we go, the final question of the day is, okay, final question of the day is, okay, and all the regular batch students will answer this, because I see this comment sometimes saying so regular ko to aata hai. So ab beta all the foundation students will stay silent, only the regular students will answer and tell me एयर साउंड अल्ट्रासाउंड में जब हम साउंड भेज रहे हैं, सो एयर उसको रिफ्लेक्ट करेगी या ट्रांसमिट करेगी? व्हाट डू यू थिंक? Whenever we are doing ultrasound and the sound beam strikes the air, will it reflect the sound or will it transmit? बोलिए. Will it reflect or will it transmit? Anybody? Okay, regular batch students, please tell me. ओके, नाउ डू यू अंडरस्टैंड ना बेटा, आपको सबको ट्रांसमिट लग रहा है ना, धीरे पढ़ना है बेटा, धीरे मेरे साथ पढ़ना है. नाउ सी दिस, इफ दिस इज योर सॉफ्ट टिश्यू ऑफ योर बॉडी, लिसन टू मी एवरीबडी, and this is a air filled structure like bowel. What happens in human body is different from what you are thinking. Sound beam goes into your body through the soft tissue to a air filled structure. Suppose the density of a soft tissue was, suppose soft tissue had a density of 10. I'm just giving an example. Air will have a density of 0.001. So do you agree air will have density much less than the soft tissue in our body? Now what happens is, in our school, if you remember from school days, beta, if you remember from school, whenever a wave passes through a medium where density is changing, the wave will bend. That principle is called as refraction. याद है कि नहीं? जहां पे डेंसिटी बदलेगी वहां पे रिफ्रैक्ट होगी, वेव बेंड होगी. But remember in school they told you, if the density is changing too much, if the density is changing too much, like where you see here, then the wave will bend so much that it will get internally reflected. And that is why air-filled structures on ultrasound appear hyperechoic. They show, and because they're reflecting the sound, they show distal acoustic shadowing. Can you see the concept here? So it is not about, foundation or regular wise, just that radiology is a little complicated. So I have to explain. If I don't explain, you will not enjoy. Okay. So it's not like a regular batch में है तो मैं उसको रटाता रहूँ ऐसे थोड़ी. I have to give you the concepts, beta. Okay, I will give you a concept before you go. This concept you already know, but I'll tell you the reason now. Now, can you tell me, why do you need a full bladder while doing pelvic ultrasound? Why? मैंने बोला ना, why बताऊंगा मैं. Okay, why do you need a full bladder while doing pelvic ultrasound? Okay, now see and understand. Because if I am now, please see, if the patient is empty bladder, my bowel loops are there in my pelvis. अगर मेरा bladder खाली है तो मेरे bowel जो होगा pelvis में आ जाएगा, bowel में air है. So I am trying to send sound into the pelvis to look at the uterus and the ovary and the prostate. Pelvic viscera देखना है मुझे, लेकिन bowel loops देखने नहीं दे रहे. क्यों? Because bowel loops are full of air. They are reflecting the sound back. They are not allowing my sound to go. Now what I do is I make the patient full bladder. This bladder is now full of water. So water allows the sound to go in and it gives me a window to look at the pelvic viscera. Do you understand this now? So the water in the bladder gives you a window to look at pelvic viscera, which you cannot see if the patient is empty bladder. Now understand, when you're doing a transvaginal sonogram, your ultrasound probe is right next to the uterus. You are in the vagina, you're touching the uterus here. There is no bowel loop in between, so you don't need a full bladder. Why are you troubling the patient? The patient will be empty bladder. Are you able to understand this? Do you now understand the concept that, okay, simple physics concepts are there, but they make sense when we try to understand them. So now what we have learned today is, I will just, go back and just show you what we have learned before we go. Okay, so this is what I have shown you today. Simple things like I've shown you how to identify gallstones on an X-ray. Okay, do you understand the concept now? Okay, we have seen how to see gallstones, how to identify cyst, why solid versus cystic. They always say ultrasound should be done. Why in gallstones, acute cholecystitis, we do ultrasound. We saw in gallbladder, if they say comet tail, do not mark stone, please mark adenomyomatosis. And we discussed that in chronic cholecystitis with cholelithiasis, you have something called as West triad. And air-filled structures on ultrasound will also reflect the sound. because of sudden change in density that happens there, acute change that happens, and that leads to a hyperechoic appearance of air and bowel loops and with distal shadowing. Everybody understands? Okay. ओके, टीवीएस में बेटा आपको जरूरत ही नहीं है फुल ब्लैडर करने की ना बेटा, आप समझ रहे हैं? आप देखें कैसे गलतियां कर रहे थे ना आप, ऐसे ही तो करते हैं इंटर्न, सोच रहे हैं आप भाई रेगुलर बैच में, इसका ये मतलब थोड़ी उसको पता है, वो जाएगा पेशेंट को बोलेगा जा अपना ब्लैडर फुल करके जा, तेरा टीवीएस होना है। मेरे पास आएगी पेशेंट, मैं बोलूंगा पहले ब्लैडर एम्प्टी करें फिर आप आए, जरूरत नहीं है फुल करने। पेशेंट इज लाइक कौन बेवकूफ इंटर्न था? डू यू अंडरस्टैंड दिस और नॉट? So you don't need a full bladder in TVS. You are right next to the uterus, you're in the vagina. You don't need a full bladder to visualize it. Bladder तब चाहिए जब आप ऊपर से abdomen से देख रहे हैं. Okay, everybody understands? Okay. Now to finish the class today, I will leave you with the message for the day, which we always do. So the today's message is, okay, now see, and let's understand this. If you mug up facts, you will not enjoy, you will get bored, you will get frustrated, and you will start regretting कि क्यों आ गया मैं MBBS में. Okay, but if you add to facts a thinking process, एक why डाल देते हैं facts के साथ में, thinking process, now what happens is you start to understand, and when you start to understand, it adds joy to the process. But now if I add to it the third component that we have not talked about so far, emotion. Okay, if I add to my studies a concept called as emotion, कि सर ये मुझे करना है, okay sir, मैंने मेरे पापा को बोला है कि मुझे ये करके दिखाना है, okay I've told my parents that I will do this, and I've said no sir, it is my passion. So emotion is, if you are passionate about your subject, or you have emotional angle attached to your pursuing a branch, that sir, I want to take up oncology because I had some problem in my family, I want to come back and do this. So if you have emotion, so this will lead to massive success in life. Okay, so difference between people who are doing well and people who are not doing well is, people who are not doing well are rote learning facts. Okay, but if you add thinking process to it, add emotion to it, it becomes massive success. That is the key. So please keep in mind, emotion is equally important, thinking why is important. And I also want you to please look back at your own journey so far and explore your why. आप क्यों आए यहाँ तक? This will give you an idea on आप आगे कहाँ जाना चाहते हैं. I wish you all the best. It has been a pleasure to teach you. I will come back tomorrow, and tomorrow we'll continue with ultrasound and Doppler. Okay. Thank you very much.